Welcome to the Improve Healthcare Podcast. I'm your host, Rich Greenhill. Today, I'm excited to speak with a global expert and leader in healthcare quality, Dr. Peter Lachman. Peter Lachman recently completed 5 years as the Chief Executive Officer of the International Society for Quality in Healthcare, ISQua, in Dublin, Ireland. His extensive experience as a clinician and leader in quality improvement and patient safety. Dr. Lachman was a Heath Foundation Quality Improvement Fellow at the Institute for Health Improvement from 2005 to 2006 and developed the Quality Improvement Program at the Great Ormond Street Hospital, where he was the Deputy Medical Director with the lead for patient safety. Prior to joining ISQua, Peter was also a Consultant Pediatrician at the Royal Free Hospital in London, England. Dr. Lachman has been the National Clinical Lead for SAFE, a Heath Foundation-funded Royal College of Pediatrics and Child Health program which aims to improve situational awareness in clinical teams. In Ireland, he is the lead international faculty at the Royal College of Physicians in Ireland, located in Dublin, where he co-directs the Leadership and Quality Program to develop clinical leaders in quality improvement. He is the co-founder and chairperson of the Pediatric International Patient Safety and Quality Community. A warm welcome, Peter. How are you today?
I'm fine, thanks. Hi, Rich. Great to have you meet with you. It's morning for you and afternoon for me.
Yeah, it's great to have you. So how are things? How's everything over in Ireland?
Well, we have been in lockdown since the 26th of December. So that is almost 4 months of lockdown in which eased last week. We can go from 5 miles to 20 miles or kilometers from the house.
Oh, wow.
But everything else is closed down. There are no restaurants, no pubs, not like Texas.
Oh, yeah. Going on great here.
Yeah, but hopefully we're coming out of it because I got vaccinated this week. And so I'm hoping that soon I'll be out of this whole mess.
Yeah. The hope is that we all are able to move forward. So, great. Well, first, coming off of a great tour, a lot of great things. I know I joined ISQua this past year and also became a fellow. And so, would you tell our audience a little bit about ISQua?
It's been around for approximately since 1985. So how much is that? Is 37 years or so. It was initially set up to look at standards in healthcare by clinicians, and that after that, it moved into other areas. So basically, standard setting. We have a program called International Accreditation Program, in which we accredit organizations such as JCI, Accreditation Canada, Accreditation Australia, all the major accreditation bodies around the world. We're the accreditor of the accreditors. So we make sure that their standards are fit for purpose. We also run education programs. You talked about the fellow, being a fellow, a fellowship program, which is mainly aimed at people who want to learn about quality and safety. And a lot of our members are on that program are from low and middle income countries. We have an annual conference this year. It was supposed to be last year in Florence, this year in Florence, but now virtually. That's one of the premier conferences on quality and safety. So as a membership organization, we have over 1,000 members and over 100 institutions that are members. So our reach is very big. We have relationships with WHO and advise them and contribute to their programs. And we also help set policy, advise on policy elsewhere. So that's basically in a nutshell about ISQua.
Oh, great. Well, I think that when I joined, I was interested in the fellowship, and I to be honest, I came in and thought, okay, what could I possibly learn? I actually learned a lot. There's a lot of great information that's shared and a lot to be learned between our global partners and all the things that different countries that are represented. So thank you for your leadership. It's certainly added value to my journey and lifelong learning journey and expanded my perspective.
Yeah, thanks. Rich, the thing about it is that no one has the answer in quality and safety work, but we've all got a piece of the answer. And if you bring people together, then you can really make a difference. That's why our motto or our vision here is providing knowledge, building networks, and giving you a voice. And we think if we can do that, then we may get to the answer that we need in order to create a safer healthcare.
Yeah, that's great. Well, given your view of quality and the fact that you've been the head of given that you've been the head of an organization that's had global reach the way it has, what do you consider to be the urgent quality issues today that you've seen cut across the globe, really?
Well, I actually think the main thing for us is going to be how do we recalibrate what we do after this pandemic. What the pandemic has shown us is that there has been a lack of preparedness, and what we thought was really good wasn't as good as it was. But on the other hand, it has also shown us a fantastic resource of people responding to the crisis. So that's quite paradoxical. So I think the major challenge will be for us to achieve universal health coverage of safe, high-quality care and to address the social determinants of health and the inequities that were exposed by the COVID pandemic. I think there are going to be many different things that we could learn and take forward. But for me, it is safety is still going to be a big issue. Person-centered care is fragile, and we really need to think about how we can make that a well-established part of what we do. And then equity, which has always been an issue.
Well, I'll tell you that when I was doing doctoral work, we traveled to the United Kingdom and spent some time in Wales, as well as several other European countries in Central American countries. And, your primary care apparatus there is just, I've never seen anything like it. It's so well done. And I'm sure you've been to Wales, in their cold country, they have patient-centered medical home, and they've been doing some things that we've been trying to do here in the United States for a long time. And so definitely learned a lot on that trip.
Well, one of the things is about, and this is the big difference between the US and the UK. The US has many different health systems. Mm-hmm. So it does have a national health system if you're in the VA, because that is a type of national health system. It also has a national health system if you get Medicare, Medicaid, So if you're old, there's a kind of a national health system. So, and then there's all the private care. Whereas in the UK, everyone has an equal right, theoretically, through paying their tax to get free health care. So I can go to my family doctor without paying anything. There's no copay. The only copay I have is in my prescription, but now I'm old enough to get free prescriptions. So it's totally free for me, but I've paid for it in my taxes, and that makes a lot of sense. Because it does allow people to achieve healthcare when they need it, and that applies to primary, tertiary care. If I have a very expensive drug, I still pay the same prescription fee as with a very cheap drug because everything's funded. So I think that's what you saw in Wales is what healthcare can be. It's not perfect, but it's free at the point of contact, which is very important.
Yeah, it was really an interesting thing to see. And the last thing on that is that the people there are very proud of their healthcare. And we saw a statue. There's a castle in downtown Wales, and we saw the statue of the gentleman who created it after the war, and he's hailed as a national hero. So it's healthcare is central to how folks over there see life. And so it was really amazing to see.
Yeah, well, the National Health Service is almost, they say, like a religion. Any politician that tries to tamper with it too much gets into trouble. And it's because health is a right, and the National Health Service is really whenever people criticize it, just say, well, just go to other places where they don't have National Health Service, and they can see the difference. The issue, of course, is how you fund it, and that's always going to be the challenge, as healthcare can be quite expensive.
That's true. Well, how do you think, and you touched on this a little bit earlier, but, COVID has exposed, people's mindsets of innovation and really exposed the cracks, if you will, globally. How do you think the virus has impacted quality outcomes in healthcare delivery, whether pro or con?
Well, basically, there are a number of issues that came out. Firstly was the fact that COVID impacted on everyone, but showed us that, particularly in the upper income countries, we hadn't really thought out how to manage elderly and people getting older. We had them in care homes and nursing homes, but that's where they were totally unprotected, and we hadn't really included them in our thinking. So I think the first thing we'd have to think is, how do we treat the elderly and senior citizens? What's going to happen, because the model we've got is not really the most ideal model. The death rate was so high in that area. The second area, of course, it exposed was the social determinants of health. And now we did know about that, but it had COVID revealed the areas in which we had poor outcomes. Now, I tend to think that this is because there's some other factors that social determinants provide, people in the lower socioeconomic classes or different disadvantaged groups have higher levels of chronic conditions such as obesity, hypertension, respiratory diseases. The diet is not as good. All these social determinants that may have been exposed even more by the virus. So I think that we're going to have to really look at how are we going to provide better healthcare for our senior community, better social care for our senior community, how we're going to get rid or deal with these social determinants and really have an emphasis on improving healthcare for the most disadvantaged, and then looking at how we provide healthcare for all that allows people to have health rather than disease. So those are the big challenges that I think are going to happen.
Yeah, you're right. And it's, you can only watch the news here to see that it's, for us, it's a political football also at times. And so, and our system, as you know, is set up backed by capitalism, and a mixture of that and some social safety net. And then that depends on the state you're in. So pretty uneven, if you will. Are there any initiatives in the UK that you think are worthy of mention around quality? Are you doing anything that is, I know myself, some of my own personal research, you're using AI a lot in some of your care processes in delivery of care, which I think is fascinating. But are there any other areas in the UK that you think are of interest?
Yeah, look, there is going to be what they're really trying to do is post-COVID move to a more automated kind of system. So what they want to do is really keep people out of hospitals in the community. And to do that, you need to use big data. You need to be able to use the latest digital technologies. You've got to take the advantage. One of the big advantages of COVID is that it took away the barrier to telemedicine and telehealth. We now have to know, how can we do this better? How can we use the wearables that you can have now to decrease the need to go into hospital? Could we use smartphone apps in a better way, in a more coordinated way? There's a whole area of the NHS that's looking just at that, at how you can use smart technology to keep people out of hospitals unnecessarily. And of course, I forgot to mention the other big threat we have is climate change. And as you move to these more digital solutions, you're going to decrease your carbon footprint of going to the hospitals and using unnecessary energy. So I think those are where the big initiatives are. And the final big initiative that I think I should mention is the idea that in the last century, we created siloed healthcare, primary, secondary, tertiary healthcare, then all on diseases, based on diseases. And now we have to move to integrated healthcare. And how can we integrate all these processes so that we get better outcomes? So those are the kind of initiatives that are underway. And the one advantage they have in the UK, which has actually 4 health services. So Wales will be different from England, from Scotland, and from Northern Ireland. But in each of these 4 NHSs, there is the national system, which allows you to make changes at scale. The key thing is to keep it out of the politician's hand, and to rather to make it in the needs of the patients, or the people we call patients. So I think there'll be lots more co-production as we move to these digital solutions.
Oh, that's great. So what opportunities do you think there are for greater global collaboration on QI and healthcare delivery? I mean, ISQua is obviously one of them, and I know that IHI also partners with ISQua and WHO, but are there any opportunities for us all to come together?
So first of all, there's this series of national conferences. We have our international journal, and I'm very pleased that you are an editor of our new journal which has just been launched online this week, the ISQua International Journal of Quality in Healthcare Communications, which is a new adventure to spread knowledge, and we're very proud that you are the deputy editor of that journal, Rich. So I think we'll be working closely with you on that one. So I think the main thing is to spread knowledge, good practice, and what didn't work as well. We have to learn that. And we have to do this at scale. As I said earlier at the beginning, we all have a part of the problem or the solution, but we don't all have the full solution. If we share knowledge and we use reverse learning from the low middle income countries to the upper income countries, from upper income countries to upper income country, and say that how can we solve this together, personally with patient safety and person-centered care. This is the decade of patient safety to be launched by the WHO at their meeting last year, but they're going to have the World Action Plan on Patient Safety, which they're going to ask all the member states how to improve. Now, in the US particularly, there's been a lot of movements on patient safety. We know what to do. It's how we implement it. That's the problem. How do we change the way people think? That's the problem. We know how to apply different methodologies, but how do we get people to do it? That's going to be the big issue and big challenge. And that's where we need to share the how and when we do the what.
I think you're onto that something there. One of the things I saw years ago, and still there's a little bit of this, is that oftentimes I will hear colleagues say, "Oh, we're so different from the UK or from Africa or from the Middle East or whatever," and that's like the way to shut out the conversation and say we're different, so we're just not going to do anything. But I saw in my global work that you can learn a lot of things from different people, even if your systems are different. There's always different perspectives. And so thank you all for having me as the deputy editor. I'm very proud to do that, and looking forward to contributing, my part. So what's next for you? So you're, great tour at ISQua, and obviously you're going to continue being a physician and doing some of the great things you're doing. Are you any other big things on the docket for you?
Well, basically, what I'm doing is I've been editing a number of books. So we have the Oxford Handbook of Patient Safety will be coming out in the next few months. The Oxford Handbook of Clinical Leadership will be followed soon after. Those are both at the publishers. The third one is the Oxford Handbook on Quality Improvement, which I have to start to write. So that's the next one. So that's my big job for the next 6 months, is writing. I also be working with the College of Physicians in Ireland, ramping up the programs and really building a succession plan. I have 10 young doctors I mentor. I'll increasing that next year. So it'll be a lot of teaching and writing over the next few times, and maybe working around the globe if I get asked. But the main thing is reflection, teaching, and writing. So a lot to do in the next few months.
Certainly. So I guess leaving ISQua, you're not going to necessarily have a big vacation.
Yeah, I don't think so. But it's going to be a different kind of thing. When you're doing reflective writing and teaching, for me, it's relatively stressless compared to running an organization. The one thing good for COVID is that I used to be on the go, traveling around a lot to various countries around the world. And then for the last year, I've sat in my house without going anywhere more than 5 kilometers. So it's been a good break for me in that sense.
Well, thank you. Well, thank you. Globalization has increased commerce and has closed the space-time gap for all of us. And the COVID-19 pandemic has highlighted the capacity and delivery issues that we all face. And so there's certainly a lot we can glean from each other. And I want to thank you, Peter, for taking time out to speak with me today and share your insights with my listeners.
Thanks, Rich. It's a real honor to be with you. For me, spreading knowledge is so important. I was really gifted. I'd been in hospital management for many years without knowing exactly all about safety and quality. And then I landed up at IHI and spending a year with Don Berwick and his team, and at Harvard, and learning about quality and safety. And that really gave me the knowledge I have now. And so my job is to give it back to as many as we can. So thank you for inviting me.
Thank you, and have a great rest of your day.
Okay, thanks, Rich. Have a good day in Texas.
Thank you.